Good afternoon, good evening, everyone. My name is Fabio Donvito. I'm the Global HIP Marketing Manager in Cori, and today I will be your host for this webinar. Thank you to be here with us. Now, with our faculty, we are going to see and understand how powerful insight can drive better outcomes. I'm starting with an introduction, and then I will give the floor to our faculty. In this webinar, we will present and discuss two main topics. The first topic will be about our new OPS review technology solution, and the second will be focused on OPS Insight. These presentations will be followed by two QA sessions. Healthcare value is one of the most discussed topics today, mainly due to the introduction of new technologies. And the main question is how we can improve it. So if we see this equation, we have two ways. We must improve the quality of our solution or decrease the cost. And this is what we are doing in Cori. Historically, the value was coming from implant innovation. The graph here on the right shows the great decrease in revision rate thanks to the introduction of the highly cross-linked polyethylene liner. But what is the future value and where we can find it? Today, most of the implants, both hip and knee, are becoming commoditized. Companies have very similar implants because the design works well. In Cori, we believe that future value will come more from digital technologies than implant improvements. And to fully release the value of digital technologies, they must be connected. What smart means? We live already in an environment where everything is connected. Think about telephone, laptop, cars, watches, and more. So why not apply the same to the orthopedic world with the Cori smart technologies? We have a clear vision in Cori. We want not only to change orthopedic, but revolutionizing it. This can be done creating this connectivity between all the stages of the arthroplasty experience. We already started our digital transformation back in 2014 when OPS was first introduced. We have created a strong foundation with our proven hip and knee implants, but the real revolution is about our smart technologies. To get more value from this technology, they must be digitally connected, and this is done via our Cori Connect. Cori Registry will be then able to collect and analyze this not structured data and transform it in actionable insight back to our customers, you. This will augment clinical decision in order to improve outcomes. And soon the insight from the Cori Registry can be used to create predictive algorithms to further enhance our implant and personalized technologies. This digital transformation must be applied to all the THA stages and not just to the surgery itself. In Cori, we can do this and we can follow and accompany you through your patient journey, starting from the patient profiling and continuing through the surgery with our connected technology. If you want to understand more about our smart technologies such as Cori RPM, please visit our website where you can find more information. Today, thanks to the faculty here, we are going to focus on two of our smart technologies, OPS Insight and OPS Review. I would like now to introduce Dr. Aubert from the Diaconess Hospital in Paris, Dr. Doman from Da Vinci Hospital in Pex, and Professor King from the University Hospital Coventry and Warwickshire.
We're just going to ask our audience a couple of questions. So the first question, very straightforward. I already see value in integrating clinical data and technology into my practice. So if you could just answer that question based on your experience, that would be great. Okay, so the overwhelming response is that people already see a lot of value in integrating clinical data. So we'll move on to the next question. So from these options, please pick the one that most closely resembles your view. So this is from my physical exam and x-rays, I can always tell what is wrong and plan the revision as needed. So it's just really to try and get an idea of where you fit right now in terms of whether you feel you could use some additional help or more information in order to help you make even better clinical decisions for your patients. So that's very good. Clearly there's quite a lot of interest in learning more and getting more information about the patient before making any clinical decisions. So that's over 70% of all of our respondents. I'll move on to the last question before I hand over to Professor King. And that last question is just very simple, and that is to say, routinely, my investigations of symptomatic THAs can include the following, and you can select a number of different answers there. Perfect. It's been great to get those 3 questions answered very quickly. So now, without any further ado, I'm going to hand over to Professor King. So Professor King, please take it away.
Great. Okay, thank you. So good evening, everyone. I'm just going to run through very quickly some of the biomechanical complications of total hip replacement and where Corin's solutions could give us some help. So when a patient like this presents to the clinic and is complaining about their hip replacement, saying that it squeaks or that it's painful or that it clunks, I usually sit and scratch my head because the x-ray looks absolutely fine. Because if I'm going to reliably fix the problem, I really need to understand the problem. And with an x-ray like that, there really doesn't look to be very much wrong. So the question is an x-ray sufficient? I've listed here all the common complications of hip replacement. And in red, we can see all these ones, which are generally related to biomechanics in one way or another. So biomechanics is a hugely important topic in understanding a troublesome hip replacement. There's papers on this that show, for example, that component orientation is important, with it being implicated in many cases of complications. Sometimes it's an obvious component orientation issue, such as a proud cup, as shown here. Edge loading, we know, is an important issue. We saw that particularly with the metal on metal problems with ARMD. But just this idea of component orientation, I think we need to think more in terms of the functional component orientation. And this image just illustrates the point that depending on the way the pelvis is positioned will influence the apparent position of the acetabulum from the AP view, and therefore will affect the functional position of the acetabulum. So just going on an AP pelvic x-ray is probably not the most reliable thing to do. And there's papers that show the variability in patients' pelvic tilt, and without going into the detail, you can see from the blue curve there that some patients' pelvises move really very differently to other patients, and therefore their cup orientation changes. This is particularly so in patients with spinal problems, and there's a growing literature about the impact of spinal deformity on risk for hip dislocation and other complications. And this probably explains this classic paper from the Mayo Clinic, where they looked at all of their dislocating hips and found that actually the majority had a cup in Lewinick's safe zone. And that's because Lewinick's safe zone was based on an AP x-ray and didn't take into account any of these issues of pelvic tilt and functional position. So really, to understand the functional position, we need to simulate it in some way. In some way, we need to analyze how the pelvic tilt and the movement of the hip impacts on the biomechanics of the joint. And this is really something that Corin is leading the way in amongst all the industry companies that we work with. So biomechanics is obviously about the cup. It's also about the stem, and it's about the choices that we make. And we know that poor choices around the stem will have major problems. So we've got a scenario here of a patient who's been lengthened because most likely the stem is just too large. Obviously, this gives a fracture risk as well. Here we have an example of a stem which has been fixed distally because it's a door A femur, and so cases like this can develop proximal pain and loosening around the shoulder. Then there's the whole issue of soft tissue balancing, and poor choices around the offset and the neck length can have major implications on whether the hip's too loose, too tight, which can cause pain, leg length problems, and dislocation. So I just come back to this point: to reliably solve the problem, you need to understand the problem. And that's where OPS review comes in. So this is a recently launched service that Corin provide. And we're going to go through this in detail with a case shortly, but just to give you a quick overview of it, you send imaging by way of CT scan and X-rays to the engineers, and they do a very comprehensive and detailed analysis of the case. And they will show you how the length of the leg looks compared to the other side. They will look at the femur, in particular femoral version. Look at the dynamic analysis of the joint reaction force as the patient sits and stands. They'll make detailed measurements of the pelvic tilt, also tell you about the lumbar spine and pelvic incidence. So really quite a comprehensive analysis. And so that's all I'm going to say by way of introduction. I'm going to hand back now, and Dr. Aubert is going to take us through a case that we can to illustrate some of these points.
Good evening, everyone. I'm going to present you a case study in order to understand what information you can have with OPS review and how it could help you to understand patient satisfaction. And so in this case, it's gonna be instability. So I'm going to show you the first one. So it's a patient. She's 81 years old, and she came for total arthroplasty with a posterior approach. So 6 weeks after that, she came back with a posterior dislocation and had a close reduction in emergency. So the surgeon did what we do in our common practice. So he did an X-ray, but it's supine anterior posterior X-ray. So what can we see on this X-ray? The only thing that we can say that's quite okay. We don't see any obvious mistakes. But if you're going closely, you can see probably an obliquity of the pelvis, so probably a long length inference. She's probably longer on the left side, and probably less offset on the left side, but it's quite difficult because you don't have the same rotation of the femurs. So what did the surgeon? The surgeon was thinking about changing the cup in order to have more anteversion, but he was quite afraid about having an anterior edge loading and posterior impingement. So he was thinking about changing the stem, but it's quite difficult because even if it's cementless after 6 weeks, you could need a femorectomy. So at the end, he chose to change the linear for dual mobility. And finally, after 6 months, she didn't have any recurrence of dislocation. But there is still one question, and that's what Professor King explained to you. We want to understand why. Why this patient had a dislocation? And OPS review is going to give you all this information to understand. So first, when you see on the screen, what you can see is that you have all major hip implants. Even if you don't use corin implants, you can analyze every patient. Even if it's a patient coming in your office from another hospital with a dislocation, you can analyze everything. So first information, and probably very important, it's a leg length difference. In this case, we can see that she's 5 millimeters longer. So it could explain a dissatisfaction, but it doesn't explain a dislocation. The second information that you can have is the offset. In this case, this is what we could have seen, is that she has significantly less offset, 7 millimeters. So we can understand that she could reduce the range of motion, probably be part of impingement, but one more time, it's probably not the only reason of this dislocation. After that, you can look at the implants and the orientation. You can have the inversion of the stems. In this case, probably less inverted stem compared to the other side, so 3 degrees compared to 17 degrees. And the last information that you can have is the supine orientation of your cup. So in this case, it's 42 degrees of inclination and 13 degrees of anteversion. So I'm going to just make a quick pause at this slide because I think that this is all the information that we have in our common practice. So when you're doing your anterior posterior X-ray and when you're doing your CT scan, it's on the supine position. So if you end with this information, you could be happy because you see that you are on your line safe zone. So you don't understand exactly why she had this dislocation. So we can go further, and this is probably the most important slide, is that what we can see is the anteversion when the patient is going from standing to seated. And so in this case, what we can see is that even if you are in the safe zone, when the patient is in seated position, she only has 8 degrees of anteversion. So you can understand why she could have an anterior impingement and so a risk of posterior dislocation. The other information that you can have, you can analyze the edge loading, the anterior and posterior edge loading in different positions. So in this slide, you can understand why she had this dislocation, probably less anteversion of the stem, she had probably less offset, and you can understand why when she's in a seated position, because she had less anteversion of the cup, she had a posterior dislocation. But with this system, and I think it's very important, you can go further and you can understand why she's going from 25 degrees of anteversion to 8 degrees. So what we can see in this slide is all the accurate biomechanical measurement. And in this case, we can see a large anterior pelvic tilt from stand to seated. So we can see that we have 24 degrees. And now we know that having 10 degrees of pelvic tilt can change by 7 degrees the anteversion of the cup. So in this case, because we have 24 degrees, you can understand how we can change from stand to seated by 17 degrees orientation of the cup. So that's why the patient went from 25 to 8 degrees. So you have more information with this system because you can understand all the risk factors for increased the sagittal pelvic motion who are causing unfavorable orientation of the cup. Because the first one is it's a patient, it's female over 75. The second one is the stiff spine. What we can see in this case, it's a lumbar flexion. It's 17 degrees. It's less than 20 degrees. And we can understand that because she has a stiff spine, she needs more motion of the pelvis. The second one is a high pelvic incidence and lumbar lordosis mismatch. So in this case, it's over 40 degrees. It's supposed to be less than 10. So one more time, it's a reason to improve the mobility of the pelvis for this patient. And the last one, it's the large posterior pelvic tilt in standing. So in this case, it's 16 degrees, right? It's supposed to be less than 10. So what can we see? With this system, we can have all the risk factors for increase the pelvic sagittal motion. So we can understand why she had a large anterior pelvic tilt from stand to seated and how it can change the anteversion of the cup. So even if you could be happy with a CT scan supine position, with this system, you can understand and probably anticipate for the patient and avoid this mistake again. Because if you can see all these risk factors, you can just change the orientation of the cup with the system and you're going to see it with a pace inside. So with this patient, the indication that you can have is what to do next. So I think that with all this information, it's still up to the surgeon to make their own choice because we all do different surgery and we probably have different philosophy. So I'm going to just give you my opinion with this case. And I think that we have two main options. The first one is probably what did the surgeon. It couldn't be my preference because of this patient because she's 81. So I think that in this patient, I would like to have a quick surgery with a fast recovery. So I think that if I want to remove the stem because it's cementless and because it's after 6 weeks, it could be difficult and you could need a femorotomy. So I think that I probably would have changed the liner for dual mobility with a little bit more anteversion and without changing the head. Because I think that if you have a long neck, if you want to restore the offset, you're going to increase the leg length difference and probably dissatisfaction. But it would be different if it was a younger patient, and especially if she was 60, I would probably consider to change the stem and the cup. And at this point, I would change the stem maybe for a lower size in order just to change the leg length. And probably it would be possible to change the head for a long neck without changing the legs length. And after that, I would have more anteversion of the stem in order to be like the other side. And after that, I think that it's going to be easier to change the anteversion of the cup, but not too much in order to avoid what we saw earlier, an edge loading, another edge loading. But it would be possible, I think, because I would have more anteversion of the stem. But one more time, it's just my opinion, and probably Dr. Roman and Professor King would have done differently. So I think that maybe we can have their point of view, and so I'm going to let them speak. Thank you very much.
Okay, if we can have our faculty back. Professor King, do you have any questions that you want or anything that you want to state right off the bat before Fabio gets into the questions?
I think, I mean, a lot of this information, if you were prepared to take the time and try and analyze the CT scan yourself, you could get some way to doing this. You could do your own x-rays and try and interpret the x-rays yourself, but it's actually really quite a complex subject. And to do it in a way, I think that's reliable and accurate. And I've tried doing it. I've done a lot of this type of planning for surgery. And you don't get anything like this comprehensive package of understanding, even just trying to do it yourself, you know. And a lot of these figures, a lot of these terms can be a bit confusing around PILL mismatch and you know, what do they all mean? But the reports make it really quite easy for you, because it just highlights everything in red and you just get warnings, so you can see pretty quickly what the likely issue is. So I think I would say don't be intimidated by these reports. You know, you should welcome them, because trying to do it yourself is really challenging.
Thanks, Professor King, and thanks, Dr. Robert. So let's start with the Q&A session. We have 9 questions coming from the audience. So let's start from the first. Why the lumbar flexion appears in red in the report that Dr. Robert shows?
Yeah. So because there is some, that's what I explained, there is some risk factor things to Langstein, and so we know that with this risk factor, it explains how it could increase the pelvic sagittal motion. And we know that if you have less than 20 degrees of lumbar flexion, you probably have a high pelvic tilt. So it could explain how it could change the orientation of your cup from stand to seated.
Okay, thank you. So the next one is a very clear question. What type of imaging do you need to get the report?
So the thing that you need is CT scan and X-rays. So I think that we are going to speak about it in the next topic with Optimised Insight. So I'm not going to give you a preview. You're going to see it after.
Okay. And how often do you feel that you will deviate from your standard practice with the use of OPS review?
In my opinion, I think often, because I think at some point you have some patient, and even if you perform what you think is the perfect surgery, I'm not talking about surgery, so we think that all we do is perfect, but you have a lot of information. And I have one example. So in my hospital, we always do an anterior approach. So we are not too afraid about dislocation, but I had one patient coming, she was quite young, and I did my anterior approach and the prosthesis. She came back a few weeks later with a posterior dislocation, which is quite disturbing for us because we try to avoid that. And so I did everything. I did X-ray and CT scan, and I had all the good position in the Levi-neck safe zone. So I didn't understand why I had this dislocation. But when I did OPS review, I understood that she had a pelvic tilt. It's 40 degrees of pelvic tilt. So she changed by 28 degrees the inversion of the cup. So she almost had retroversion when seated. So I understood everything. And at this point, I understood that I need to be more concerned about pelvic tilt and that I need to anticipate this case in order not to redone the same thing. So I think that it's perfect for the surgeon, probably not to change how you're going to manage the patient after, but probably to understand why it went wrong and how can you anticipate that to just change your practice.
Okay. Professor King, your point of view?
Yeah, I mean, my point of view is that we should be doing a lot more cross-sectional imaging of hip replacements when we're thinking about a revision. I mean, we do CT scans all the time for trauma. We scan liberally in many aspects of orthopedics, and I think for some reason we've never really done that around hip replacements, and I don't know whether that's historical because we thought, well, there's too much artifact, etc., etc. But the amount of information you get from this approach to often a very difficult situation, the amount of information is fantastic, and really, it's a challenging enough operation often, and you really want to go into that with your eyes wide open. So from my point of view, unless I've got a clear-cut reason for needing to revise the hip, such as gross loosening or infection, then I would do this in every case.
Okay, thank you. Another one, is OPS review a planification tool for revision?
Oh, so I think that it's going to help you to have all this information, but the thing that after that, it's your own choice. So you can choose what you want to do. This is what we saw in this case. So I think that, yes, you have a lot of tools, especially if you want to train everything and just to improve your practice, yes, you're going to use it. But I think that one more time, I think that most of surgeons could just imagine it. It's easy to do a revision with just CT scan and X-ray. And when they're going to use OPS reviews, they're going to understand how powerful it is and how we have all the key to understand our surgery and to manage patient.
I would say that, yeah, it's an analysis tool. I think really is what it is. I mean, will it evolve to the point where it's a planning tool? I would imagine so. I would imagine that you will have the analysis and then there will be a suggested solution to that analysis. But at the moment, it's just the analysis. And then obviously you as a surgeon make that decision, take the decisions yourself.
Okay, thank you. Very important question here is, can OPS review be used with implants that are not manufactured by Corin?
Yes.
Okay, let's finish with the last one, is a bit technical. When do you consider that there is a risk of dislocation or anterior edge loading?
So when, before, after you're taking before the surgery, or for the, because I think that it's quite difficult, and this is because I don't choose OPS for all my patients, because when you're performing 8 total hepatoplasty per day, I just can make 2 or 3. But I'm trying to find every risk factor in patients. So if they could have spine surgery, arthritis, or if I see on my supine anterior posterior X-ray a large posterior pelvic tilt, I'm going to use OPS because I'm quite sure that I'm going to have a large pelvic tilt.
Okay, thank you. Professor King, you want to add something?
I think what the question was about how do you identify from the report, the OPS review report, that you've got edge loading or impingement. I think that's the question. I mean, they'll show you the analysis, they'll show you the plot of the joint reaction force, and then they will identify, they will flag to you as an alert that this is at risk of impingement and risk of edge loading. And those alerts are based on literature that show what is a safe amount of distance between the joint reaction force and the edge of the cup. So you can, everything that's in those reports is driven by the literature, by evidence base that says this is why we're saying that.
Thank you, Professor King and Dr. Robert.
We just have one question, Fabio. So I've just made question 5 live. So if we have all of our surgeons, if you could just take a look at that poll, we'll just give ourselves a few seconds to get that poll answered.
Okay, we're now talking about planning for a primary total hip replacement. And I think nobody would disagree with this. We should all be aiming for perfection every single time. We want to give our patients a 100% guarantee of a very good hip replacement. And as we've said, as Fabio mentioned earlier, most companies now are producing great implants that you can reliably fix. But the other key part of getting a good hip replacement is getting the biomechanics right. And I think those 3 things are foundational. And biomechanics, I think, is where we've still got work to do, and OPS is leading the way here. So just going back to my previous list of the complications of hip replacements, so we've seen how biomechanics can be implicated in so many of these. And so really, when we're planning a hip replacement, we should have a biomechanically intelligent surgical planning system, and then a way of delivering that accurately, because clearly a plan is not that useful if you can't deliver it, and a delivery system is not that useful without an intelligent plan. And these are the things that that Corin have made available. So on the left we see a screenshot of the planning system, which is underpinned by the OPS technology. And on the right, we see a graphic of the procedure using patient-specific instruments and a laser system for guiding the implantation. So just to remind you then, we are recognizing now when we plan that the pelvis is not a static structure, that it tilts forwards and backwards, and these things need to be factored into accurate planning of the cup. So there was a question about what x-rays, what imaging we provide. Well, we need to provide to Corin these 3 images of the lumbar spine and pelvis. So the patient is asked to stand, and then in the second x-ray they're meant to simulate rising from a chair, and on the third image that shows the patient stepping up with the opposite leg, and so effectively performing a standing Thomas's test. And so those images really give you a functional range of hip flexion for these key activities of daily living. And those x-rays look something like this, and the engineers in Corin will mark out the end plates of L1 and S1, and they'll mark the anterior pelvic plane and then see how they change with these various postures. The patient also has a CT scan, and that's done to a particular low dose radiation protocol, which is a scan throughout the pelvis, a few slices through the knee and the ankles. And then those images, the X-rays and the CT, are used to generate a evidence-based simulation of the hip of that particular patient. And this, as you can see on these images, we've got arrows that depict the joint reaction force. So these simulations can show where the joint reaction force will pass across the face of the acetabulum. And this animation shows that you can then identify a problem. So if you planned, in this case, a cup at 40 degrees and 15 degrees, then in deep flexion, the patient is edge loading posteriorly. And so with this information, the plan can be adjusted so that the plan is therefore optimized for that patient and minimize the risk of posterior edge loading and dislocation. Once you're happy with the proposed plan, then you're provided with sterile PSI surgical guides that you use to indicate the position that you want to achieve intraoperatively. So this is what OPS Insight looks like. So you send all your imaging off to Corin, you upload the case through the portal here, and then within a few short weeks, you will receive a plan which has been done by the engineers for you. So really, you don't have to do very much at all as a surgeon. You could just simply accept the proposal, but you have full flexibility to explore the plan and to make changes as you see fit. So we have a page here that shows the dynamics of the hip, in particular looking at this slinky plot, as you can see it on the left, showing the joint reaction force. And you'll see in the next presentation how you can run an animation to show that working. We then have a tab focused on the cup, which gives you freedom to change everything about the cup, position, orientation, and sizes. And finally, a tab to look at the stem. And you can play with all of these things and tweak the plan as much as you feel is necessary. So that's OPS Insight, a very, very powerful tool in preoperative planning. And I think for me, it's the best planning system available today, because it's the only one that really factors in the biomechanics. So with that, I'm going to hand over to Dr. Duman to run through a case.
Good evening, everyone. So I'm going to present the case. Let's see the case details first. So this is a 71-year-old female patient, and the left hip is going to be analyzed. In the key banner, first thing we can see is the warnings here. We have three main warnings. There is an anterior prosthetic impingement risk, and the second is that the stem is planned below the osteotomy, and the imaging is older than 6 months. This is something we do not recommend because in 6 months' time, the bones can change a lot. The next thing we can look at is the comments. We have engineering comments, and also surgeon can leave their comments. In this case, the stem head combination has been planned to target the contralateral implant head height. The other comment is that the cup has been planned on the true acetabular floor. Normally, it's done 2 millimeters off from the floor, but in this case, to avoid shell coverage, the cup was medialized. As mentioned earlier, the surgeon can also leave their own comments, but it will be not forwarded to the engineers, but can be considered for the clinical report. In this case, the surgeon noted that there is a need to lengthen to match the other side, and he will check it clinically. The next thing we can look at is the measurements. The cup orientation was chosen here as 38 degrees abduction and 18 degrees anteversion. These two numbers are highlighted in red. That means that the reason for that, there is a risk of anterior edge loading. Normally, OPS provide an optimized cup position where there is no anterior prosthetic impingement or edge loading. In this case, when there's a normal situation, the numbers are in green. In this case, on purpose, deliberately, we have chosen a situation when the cup position is not normal, is not optimized, just to show how the system works. The next thing what we can look at is the spinopelvic parameters, the pelvic tilt parameters. We can see that one number is highlighted. This is the stand to flex seated, the pelvic tilt in from standing to flex seated activity, which is huge, more than 20 degrees, exactly 23 degrees, which decreases the functional cup anteversion a lot, and this is leading to prosthetic impingement. If you look at to the dynamic tab, we can see from the lateral view the pelvis, and if we play the simulation, we can see that the patient is going from extension to flex-seated activity. The pelvis is tilting significantly, and at the end stage, we can see that there's anterior prosthetic impingement. We have the warning here, and if you look at from the side, we can see a red area where the neck getting contact with the rim. We can also see that in this situation, the functional anteversion is 6 degrees. Okay, after that, we can look at to the X-rays on the right-hand side. We can see the X-rays, periodic X-rays in different positions, standing, flex-seated, and step up. And if you go to the advanced tab, we can also see the measurements, all the spinopelvic measurements which were used to make the calculations. We can see that, for example, the pelvic tilt in a standing position was -4, while in the flex-seated position was +19. So that's why this huge 23-degree pelvis onto rotation. So next thing we can see here in the key banner is the information about the leg length. The hip was 40 millimeters short preoperatively due to the previous hip surgery, and there was a lengthening of 2 millimeters, and the global offset change was -1 millimeter. The engineers were trying to always match the native version of the patient. In this case, the stem version was 23 degrees and very close to the native version of 24 degrees. The next thing we can look at is the contact mechanics. Here, this is the contact patch that refers to the cup position which has been selected. In this cup position, there is no risk of anterior posterior edge loading. Why we know this? Because the red trace we see here, which refers to the joint traction force acting on the liner when the patient goes from extension activity, from standing position to extension activity, is centered right in the middle of the plot. If it was very close to the rim, we would say that there is an anterior edge loading, but this is not the case. If you look at the blue trace, which refers to the joint traction force acting on the liner when the patient goes from standing to flex-seated activity, we can see that it doesn't reach the rim of the contact patch. If it would at the rim or leave the rim of the contact patch, we would say that there was a posterior edge loading or dislocation, but this is not the case. So the main issue here what we are facing is anterior prosthetic impingement, which is caused by this huge anterior pelvic tilt when the patient goes from standing to flex-seated activity. This is happened because the cup anteversion is reduced a lot with the anterior pelvic tilt, and let's see what we can do with it. By gradually increasing the anteversion of the cup, we can see that there is an update, real-time update on the contact patch. By increasing to 21 degrees, the warning disappears. So the anterior prosthetic impingement problem being solved. And we can see in the key banner that the numbers turn to green. We can also check the bone impingement. We have a button here. By clicking on the button, the bone will appear on the top. We can play again the simulation and see if there's any bone impingement. It can be very useful if we have osteophytes, but this is not the case. But we see here at this point, we see impingement on the pelvis, but this is not an osteophyte, so we can't do really too much with it. On the left-hand side, we can see the implant type we have used. We have used the Trinity 48mm cup with a ceramic liner. We have Trinity TS stem size 5 and 127 lateralized, and ceramic head 32mm -4. We can change any of these implants, and we will see a real update in all the parameters and banners. The only thing which will not update in real time is the contact patch, contact mechanics. Next thing we can look at is the stem tab. We can see in 3 planes, the coronal, sagittal, and the axial plane, by scrolling through the CT slice, how the stem is positioned. We can make adjustments with the control panels here if we want, change the rotation or move the stem. We can also see it in the axial plane. We can check the slides through how the stem fits in the bone, in the canal. Another interesting feature is the radiodensity feature. If we click on the positive X-ray, we can see how the implants will be positioned after the surgery, how it's meant to be. And if we click on the radiodensity button, we will see the bone density appearing on the screen. The color representation is the color representation of the bone density at the bone stem interface. This is very helpful to make a decision which stem we want to use, because if we have high density, it will be represented by red or yellow color. If we have low bone density, it will be represented by blue. If, for example, we are using this time a Trinity TS stem, we would like to have proximal loading of the stem. In this case, we are expecting more yellow and gray around this area. And since we don't want to have cortical contact around the tip of the stem, we would expect blue color. What we can do is also, it's nice to compare the coronal CT views with the anterior view of the post-op X-ray with the radiodensity. We can also check the sagittal view with the lateral view on the X-ray, so we can see in 3D how the stem is planned. We can also check the osteotomy plane. It's important to know how to enter the femoral canal during the surgery. We can see the osteotomy line on the coronal view as well. And if you would like to avoid, for example, the step cut, we can just go into the advanced measurements, advanced tab, and scroll down and click avoid step cut button. And in this case, the measurements will update. And if we look at the 3D CT, we will see how the implant will look like after the surgery. After this, we can go to the cup tab. We can scroll through the CT slides again in 3 different planes, and we can see how the cup is positioned. We can make adjustments on the control panels. If we want, we can observe, see how's the bone stock behind the cup. We can make adjustments if we want to see going up in one size, how this would change the plan. And another important feature is the cup coverage. In this case, I just click reset. I'm going back to the optimized. We have 1mm cup coverage, but we know clinically that if the cup is uncovered, it can be a problem causing psoas impingement. So in this case, we can medialize the cup. We can see what happens in real time. By medializing the cup, we can see that the cup coverage is increasing, and we can also see on the 3D view the cup moving medially. If we have too much coverage, we might have osteophytes and bone impingement. We can check this on the dynamic tab, and we can play the simulation if we want. If you want more details, we can also go back to the Advanced tab and scroll up and down. Beside the spinal pelvic parameters, we have further details about the leg length, head height, greater to canter distances, native femoral offset, etc. And then, if we are happy with the results, we can just click validate, and the engineers will receive our adjustments and will be ready to manufacture the PSI guides, which can be used for the surgery in order to recreate, along with the laser system, to recreate this plan. The system is very accurate and very reliable and very easy to use. Thank you very much.
Thank you, Dr. Doman, and thank you, Professor King. We have just few minutes. I know PS Insight is a lot of information. This is the beauty, but at the same time, it's very simple. I have a few questions here. I have 12 questions. Let's see if we have enough time for all of them. So let me start with the first. Assuming you don't plan all your patients with OPS, how do you choose the ones who will go through the OPS?
Professor King or me?
Yeah, so from my point of view, I would like to do it. I'd like to do it on everybody, but practically, I reserve it for the younger patient. If I did it on all of my patients, my CT scan department would stop me. So I just have to have a process of selecting the right patient. But certainly, any patient who I think clinically has a high risk, such as a patient with a previous spine surgery, or say a confused patient, you know, if it helps, then if I can, I will do the OPS.
My opinion is the same. I use it mainly for young patients, and also those patients who are having spine problems or had previous spine surgery. But I try to pass it all young patients to have the OPS measurements, because this may increase the longevity of the implant. So that's very important for them.
Okay, thank you. So how much time does it take for you to analyze an OPS inside case?
5 minutes.
5 minutes,
yeah. Occasionally you'll see a problem that the engineers haven't been able to address for you, and I'll spend another 5 minutes playing around, maybe try an offset liner. So in this case, for example, I might have looked at an offset liner and a cemented stem to deal with that bony impingement. So you can spend 10 minutes, but usually it's 5.
5-10 minutes, yeah.
Okay. Yeah, there is another question that is similar to this. So we jump to, how can you recreate the plan intraoperatively?
So as I mentioned in my talk, there's PSI guides are provided. So that does allow you to recreate the acetabular orientation really very well. We've just done a paper on that, which we're hopefully going to publish soon, which shows that 94% of our cups are within 10 degrees, which is certainly as good as any other system out there. In terms of the depth of the reaming, in terms of the exact positions of the femur, again, the plan helps massively. It's not quite a robot, I get that, but I think the value that the analysis brings is far more powerful, to be honest, than any sort of robot.
Okay. Very specific question about specific indication, if OPS Insight can be used in patient with dysplasia, for example.
Yeah, absolutely.
And did you find any benefit?
Personally, I try to use it in all complex cases, post-Perthes, dysplasia, post-trauma, which are very complex to see. Even the CT plan itself, just the post-op X-ray can just help. The surgeon also sizing and etc. You can avoid fractures intraoperatively, and other problems, implant inequality, etc. So it's really very useful.
Okay, the last question. There are some more, but we will try to answer to the rest and send to the audience a follow-up after this meeting. Is regarding the information. So do you need to do the plan from scratch, or do you get a suggestion?
You get it. It's fully planned. It's fully planned, and you can, you know, if you don't want to review it at all, you could just click validate, even without looking at it. but I think if you're going to go to the effort of doing this, it's worth spending 5 minutes looking through it.
Okay. Thank you, Professor King. Thank you, Dr. Doman. I think because it's now almost the end, I will just close the WebEx with a couple of few slides, less than 2 minutes. So we discussed before about this concept of connectivity and smart technology, but what is the value of this connectivity? We have seen OPS Insight and OPS Review today, but all our smart solutions, also RPM, they all bring value by themselves. So what is the added benefit of this connectivity? We have two answers. Firstly, we want to provide the best customer experience, one access point for all our technology. Secondly, thanks to the actionable insight generated from the Corin registry, for the first time, the surgeon, you, will be able to quantify how decision made preoperatively or intraoperatively can affect the outcomes. So you can modify aspects of the patient care to improve the future patient outcome. In summary, what we want to do here is to revolutionize orthopedics by gaining, understanding, and sharing insight at every stage of the arthroplasty experience. And this can be done already via our digital ecosystem that is Corin Connect, available now. Why the smart way to operate? Because we combine these elements of connectivity and we are able to transform all the information generated by our technology in something that can be quantified and improve the healthcare value. So before to leave you, just a reminder, I hope you enjoyed the webinar today. We will have another excellent one next week, which will be focused on our amazing new technology. So thank you again, and to the faculty and to all of you, and enjoy the rest of the evening. Thank you.